So we've assessed our patient, we've performed our procedure, and they've recovered. So now we're going to figure out how to determine if UFE has done a good job for our patient. And we typically measure the outcomes after fibroid embolization in three different ways. The first is symptomatic improvement, the second is uterine and fibroid volume reduction, and the third is fibroid infarction. Now, interventional radiology has done a great job figuring this all out, and there's been a very robust evolutionary pathway concerning the studies that have been performed in order to assess the outcomes after UFE. And this has progressed from case studies and small case series to a national registry to both single center and multi-center comparative trials. The case studies and the small case series have really focused on symptomatic improvement. And what they've shown is an improvement in menorrhagia, ranging from anywhere from 79 all the way up to 98%, an improvement in bulk-related symptoms ranging from 65 to 98%, and an improvement in lower urinary tract symptoms. Some more recent studies have shown an improvement in premenstrual symptoms like back pain, headache, and GI symptoms. And finally, there are studies which show an improvement in sexual function. Now, back in the early 2000s, there was a multi-center registry that enrolled over 3,100 patients, with 2,600 of them evaluated at 6 and 12 months after their fibroid embolization procedure. This study utilized the UFS QOL questionnaire. That stands for the Uterine Fibroid Symptom and Quality of Life Questionnaire. This is a validated tool which measures the symptoms and health-related quality of life in association with fibroids. The symptom items of this questionnaire address both the frequency and severity of fibroid-related symptoms, and the health-related quality of life items addressed included fatigue, sleep, self-image, mood disturbance and psychologic distress, fear of embarrassment, interference with daily activities, relationships with family and friends, and sexual functioning. The findings of the registry were actually quite revealing. When you looked at symptom control, the improvement in symptoms went from the baseline score to a level that was even better than the normal population all the way up to 36 months. And the same thing when you looked at health-related quality of life. At 12 months, the score was just about the same as it is in the normal population. Following the registry, there were several comparative trials that evaluated UFE in comparison to GYN surgery. So there were trials looking at UFE versus hysterectomy, UFE versus myomectomy, and UFE just generally versus surgery. When you look at these comparative trials, it's important not to forget that the earliest studies were actually performed to obtain 510(k) clearance from the FDA for use of the embolic agents in this procedure. The comparative nature of the study was really secondary, with the primary goal being to demonstrate safety and efficacy of the embolic agent being studied. Therefore, the statistical power was limited since we didn't have the data needed to determine the appropriate sample size for these studies. The first study was a trial for embosphere microspheres, and in this study, 152 patients were included in a non-randomized study, with 102 being treated with fibroid embolization and 50 being treated with hysterectomy. Remember, the study was being powered to look for adverse effects resulting from the microspheres rather than to show a difference in outcome between the two procedures. This study showed that UFE patients had a significant reduction in blood loss at 3 and 6 months, while hysterectomy patients had improved pelvic pain at 12 months. Both groups had similar improvements in other symptoms and quality of life scores. The complications were more frequent in hysterectomy patients, and there was no difference in complications within 30 days of the procedure, but hysterectomy patients had more complications after 30 days. The hopeful study was a retrospective multi-center study comparing UFE and hysterectomy. The study had a mean follow-up of 8.6 years for hysterectomy and 4.6 years for fibroid embolization. And the study showed that there were fewer complications in the UFE group, that more patients in the hysterectomy group reported symptomatic relief, but more patients in the UFE group would recommend the treatment to a friend, compared with patients in the hysterectomy group. The REST study, which was reported in 2007, was a randomized trial comparing fibroid embolization with surgery. Randomization was performed in a 2-to-1 ratio of UFE to surgery. The study needed 200 patients for 90% power, but they did have some recruitment difficulties which lowered the statistical power to 80%. The study showed no significant differences in quality of life between the two groups at 12 months. The surgery group had significantly better symptom scores at 1 and 12 months, though, compared to the UFE group. The UFE patients had less pain at 24 hours, a significantly shorter hospital stay, and a shorter time to resume normal activity than hysterectomy patients. A subsequent analysis showed that the reintervention rate for fibroid embolization was 32% at 5 years. Finally, a big study that was performed out of Europe was the EMI study. This was a multi-center randomized controlled study conducted in the Netherlands from 2002 to 2004 at 34 hospitals, and there was a 1-to-1 randomization with fibroid embolization and hysterectomy. This study showed that 31% of fibroid embolization patients had a hysterectomy after a technically successful fibroid embolization. Both groups had a significant improvement in health-related quality of life during the first 6 months. By 10 years, both groups had improved significantly compared to baseline, with no differences between the groups. A failure of fibroid embolization within 10 years was associated with a high BMI and with smoking. And at 10 years, most patients were satisfied with the treatment that they had received. There have been some well-publicized thoughts about this trial. It's important to keep in mind that this was a multi-center trial with differing levels of expertise, especially early in the days of fibroid embolization. And a lot of people suspect that the results would have been different if the study was done today. This is because hysterectomies are progressively done by laparoscopy, and the technical failures for fibroid embolization are much less prevalent than they were almost 20 years ago. Several trials also compared UFE versus myomectomy. Scott Goodwin in 2006 reported on a prospective, non-randomized study comparing fibroid embolization with myomectomy, and the group assignment was based on individual patient decision. In this study, both groups demonstrated an improvement in overall quality of life, health-related quality of life, menstrual bleeding, and uterine volume. The fibroid embolization patients had a shorter hospital stay and a faster return to normal activity and to work. In addition, the fibroid embolization patients had a lower complication rate. The FUME study, which compared UFE versus myomectomy, was published in 2012. This was a 1-to-1 randomization of 163 patients, and this study showed an improvement in health-related quality of life in both groups. Fibroid embolization patients had a shorter hospitalization, which was 2 compared to 6 days. There was no significant difference in complications between the two groups, and at 2 years, the reintervention rate was 14% for fibroid embolization and only 2.7% for myomectomy. Importantly, half of the women who needed a hysterectomy had adenomyosis that was missed on ultrasound. So given all of these studies, I would just like to review a couple of take-home points. Fibroid embolization was shown to have a shorter duration of hospitalization and a faster return to work. There was no significant difference in symptomatic improvement or improvement in health-related quality of life between fibroid embolization and any of these surgical options. However, hysterectomy was shown to improve at least one symptom better than fibroid embolization, and myomectomy seems to have a better reproductive outcome than fibroid embolization. UFE patients have a higher rate of satisfaction, and more of them would recommend this procedure than a hysterectomy or a myomectomy. And finally, fibroid embolization has a lower rate of adverse events compared with surgery, although the minor complication rate is higher with fibroid embolization. It's also important to look at the GYN intervention rate, and somewhat intuitively, as you move from 2-year follow-up to 10-year follow-up, the rate of subsequent GYN intervention increases. At 10 years, it was over 30%, which was reported in that 10-year follow-up of the EMI study. Another way that we typically look at outcomes after fibroid embolization is by studying uterine and fibroid volume reductions. Now, this is probably the least important of the three ways to measure outcomes, but patients love knowing this information. And it's reasonable for most patients to expect a 35 to 65% uterine and fibroid volume reduction after fibroid embolization. Using imaging, however, the best indicator of long-term success after fibroid embolization is fibroid infarction. It's very clear that viable fibroids increase the likelihood for symptomatic recurrence. MRI is the best way to assess patients after fibroid embolization because it's the best way to assess fibroid infarction and continued myometrial perfusion, which is why we like to get an MRI at 6 months after the procedure. All of this began when Jean-Pierre Pelage in 2004 published his case series. His group was the first to report the importance of fibroid infarction and the development of recurrent symptoms in patients without fibroid infarction. I still love looking at the pictures from this study. If you look at the picture on the left, this is the pre-procedure study. And following fibroid embolization in this particular patient, you can see how the uterus looked on the right. And what you notice is the dark color of the fibroid indicates fibroid infarction throughout most of the fibroid. But there are 3 distinct areas that have continued perfusion, which is indicative of ongoing viability. If you then take this series of pictures over a period of several months, you can see how the viable tissue grew even though the overall size of the fibroid decreased in volume. So in other words, the fibroid shrunk, but the amount of viable tissue increased, and that subsequently increases the risk of symptomatic recurrence. These findings were confirmed by Katsumori in 2008, and his group showed that as the rate of fibroid infarction increases, the rate of symptom control increases, but the rate of additional GYN intervention decreases. The bottom line here is that if fibroids do not enhance on post-procedure imaging, then they are infarcted and should not be a problem in the future. Women with fibroid infarction above 90% on MRI after UFE have better symptom control and fewer reinterventions than patients with a lower infarction rate. This is especially true in patients presenting only with abnormal bleeding. At the present time, decisions to reintervene on a patient who demonstrates enhancement on post-procedure MRI should be based on whether that patient is symptomatic. If something different can be offered to a symptomatic patient, then I think a repeat UFE can be considered. And these different things include ovarian artery embolization, a more aggressive embolization endpoint, a different embolic agent, and perhaps the use of microcatheters to avoid spasm. So all of this really comes down to whether or not it's worth doing a repeat embolization in these patients. And it's then important to know that repeat UFE may be inferior to the original procedure. A more recent study in 2017 showed lower tumor infarction rates, shorter periods of symptom control, and lower uterine volume reductions with a repeat fibroid embolization. So it's important to remember that because you just don't want to jump in to a repeat UFE if the initial index procedure didn't end up as well as we would have liked. So in conclusion, UFE has been extensively studied as an option for treating patients with symptomatic fibroids. Dozens of studies have shown the following: that UFE effectively treats the symptoms associated with fibroids, it results in significant uterine and fibroid volume reduction, and it addresses fibroids in a manner that's comparable to the outcomes seen after hysterectomy and myomectomy. Hi, this is Dr. Gary Siskin, continuing with the UFE lecture. This is part 4, and we're going to be talking about outcomes.